Good afternoon. You're all very welcome to our session this afternoon. I'm Shane Devlin, Chief Executive of the Integrated Care Board for Bristol, North Somerset and South Gloss. We'll just do a quick round of introductions.
I'm Suzanne Bailey. I'm an analyst and work in the research and development team at Akumen, who are based in Cornwall.
I'm Matt Hill from South Devon. 2 young boys and spent a lot of time at the rugby club. When I'm not there, anaesthetist in Plymouth, and until recently working as National Clinical Advisor in NHS England around safety culture.
And I'm Marc Griffiths. I'm a Pro Vice Chancellor for Health here at HIWE Bristol. My professional background is I'm an AHP, I'm proud of it. I'm a radiographer. I used to have a lot more hair back in the day. And I'm also charged with leading something called the Integrated Care Academy, which you may or may not have heard about. I've tried to do my best over the last several months, but yeah, that's what I've been charged with here at HIWE Bristol. And it goes back to comments today around breaking down silos, breaking down barriers, and doing the best that we can to work with each other. So there we go, long intro, sorry.
Okay, so what we're going to try and do is have a bit of a conversation with regards to the challenge of culture, productivity, transformation and innovation. And I hope will be a very interesting session, because I think we have some really big challenges about how we allow our workforce to really take risk, how we allow them to try in safe environments, and how we learn from that. Okay? Particularly in the context of a health service that is probably quite rigid, best way of putting it. And if you've had the pleasure of following the HSJ or following what's been going on in the last couple of days, potentially could become more rigid with regards to performance targets, league tables and all those kind of things. So this is a real dilemma. How do we get the best out of our workforce to be really innovative in an architecture that might not always support that innovation? So we're really trying to explore some of that today and see where the conversation takes us to. And for me, as the Chief Executive of an ICB, productivity is something that is constantly on my agenda, okay? And sometimes put by me and sometimes put by others. But the reality is NHS has more staff than it's ever had before. And that's hard to believe at times, but it has. It's also got more money than it's ever had before, but the argument is it's also not as productive as it needs to be, okay? And therefore the challenge is, how can we drive productivity and innovation and a culture change in an architecture that we have? So I'm really interested to begin the conversation, and I'm going to ask Matt to start the conversation, that if we are to survive in this place, a safety culture is so important. So could you talk to us about sort of how safety, innovation, transformation and change can work in this environment?
Yeah, thank you. I suppose my view of safety culture is it's absolutely fundamental to how we learn safely. Having said that, we spend a lot of time paying a lot of attention to culture, and we append it to lots of other words: safe culture, learning culture, improvement culture, just culture, without really understanding what we mean by culture. I suppose that's where I've spent the last sort of 20 years of my life, delving into what we mean by culture and doing an awful lot of learning on the way. I've not always got things right, but that learning's been really invaluable in understanding, hopefully, a more constructive way of understanding what we mean by culture. And I suppose the first thing to say is I see it as a dynamic social construct. It's constantly shifting. This isn't static. And yet we often only pay attention to it when things have gone severely awry. Look at the national reports coming out in Ockenden and elsewhere, but that's the time it tends to come up. We don't do the constant gardening to pay attention to it during the normal times. And we're so busy doing, in contrast to that productivity, but we're measuring activity rather than what we're actually achieving and how we achieve it. The second part of that, the social construct part. We are incredibly social beings. We thrive with each other, we need that contact. But we've designed a lot of times we used to meet up out of the system. We no longer have a lot of those informal meet-up spaces. Coffee rooms have gone to offices and other bits. We've got teams. So how do we come together? And if we're not together, we won't build trust, we won't build psychological safety, all those elements that are so important. We need to spend time together and see this as work. The other way of seeing culture is taking a really, really appreciative view of it. What are we trying to achieve when we look at culture? And hopefully by looking at what we're trying to achieve and saying it's for all of us to flourish, be that staff members, patients, families, carers, all of us in the system, and we all need something slightly different to flourish, but also in what we're trying to achieve brilliant care. And in that brilliance comes subjectivity. I need to be curious to find out what that looks like to each of us. I need to invite that conversation, have time for those conversations to really understand what that looks like. And through that, we understand each other, we trust each other, and we can really appreciate how to do things better. And that's where I want us to get to in our focus on culture. And through that comes the discretionary effort, the engagement, the greater productivity, by really understanding and paying attention to how we do things rather than just what we do.
Great saying that. We see culture as work. That's a really interesting thought, because actually we often see work as work, doing stuff, producing stuff, but actually we need to start seeing culture as work. We'll come back to that. Make a note, we will come back to that. I think that's a really fascinating concept, because how many of us actually see culture as work. We see the product we have to do, the patient we have to see, but seeing culture as work. I'm going to come back to that. Suzanne, thoughts? I mean, what's your thought about how that culture, safety, productivity all sort of connects together? I'll give you this one.
Okay. So I see things from a slightly different perspective. I'm not in the health service. I have never worked in the health sector at all. So I'm coming from the place of an analyst, and we analyse what happens in people's lives, what happens to patients in their experience of health service, and you know, we also look at employee experience in the NHS. So we see what kind of goes right and goes wrong depending on the environment. And obviously culture is a big subject. It enables people to flourish and thrive, but it also can be quite destructive in terms of somebody's well-being. As well as being an analyst, I'm also a therapist. So I see when culture is destructive, where it has a real impact on people's health, where it can stop people bringing their 100% talents, their enthusiasm, their creativity, their passion into the workplace. It can stamp it to the ground. A culture, if working in its kind of positive aspects of culture, it can make people feel amazing about themselves and what they're doing and have a real impact on productivity because they are fully engaged, not disengaged from what they're doing. And through the narrative that we analyse, we can see and track how culture can make or break the individual, the team, the organisation. Through the, we look at the dialogue that comes back in that feedback loop, and that feedback loop really is such a valuable instrument in creating and driving a decision-making kind of evidence-based kind of decision-making from the bottom up, not from the top. So that feedback loop can really have a huge impact, not only on culture, but also on productivity. And it's sometimes a shame that in the public sector, it's really not valued as much as in some of the commercial multinational organisations that I've been working with in the last few weeks to create a culture among over 50 countries with people from very different backgrounds, ethnicities and environments. So we can in very complex systems create culture, but it needs a different approach. Shane?
Before I'm going to let you off the hook, it needs a different approach.
Yeah.
What is that different approach? What do you think when you look at the NHS? What is that different approach?
So from what I've learned in my jobs, never before have we had the technology to enable us to gather the experiences, knowledge, wisdom of so many brilliant people. We've always looked upstream to the leadership, to individuals to determine the direction and make the big decisions. We have got the technology now to accumulate hundreds of thousands of people's wisdom and experience, so that if 3,000 people in your organisation say this is the major frustration that they have every day, it gives you a really good evidence-based approach to make very valuable, low-risk decisions. So, if leaderships are worried, people in the top leadership are really concerned about the high risk of innovation, lower the risk by gathering the evidence. And the evidence is amongst all of the people who work in the NHS, in my opinion.
Thank you. So we listen hard and listen good to our people because they'll give us the answer.
Yeah.
Marc, you have a huge responsibility on your shoulders, okay? So as a ICB Chief Executive responsible for a system, you are the one who are guiding our new people into health and social care through the university in terms of training our next group of individuals who run the health service and for our population. How are you going to get a culture that we need whilst in that early stages of training, learning and development for those people?
Thanks, Shane. That's a great question, one which puzzles me at times, I must admit. I'm just also trying to resurface from Suzanne's answer there, because I took somewhat from both of those answers. I'm thinking, wow, how can I weave that into my answer? But so yeah, roughly train around 3,500 health and care professions here at HIWE Bristol. Cover a wide range of top subjects, all the nursing fields, midwifery, a multitude of AHPs, optometry, physician associates, and we have great links across the regions as well. I think the one thing that that comes to mind, Shane, is having to innovate the curriculum and having to make sure that the curricula and how you design that. And when I did my training, which is many years ago, we didn't really talk about co-creation of curricula or learning outcomes or assessments or simulation. But now there isn't, quite rightly, an expectation that you co-create the design of your curricula, you make it diverse, and you bake that in. You don't do it as an add-on. You look at the range of technologies you use. Are they diverse? So, for example, I remember 8, 9, 10 years ago, all the mannequins which we use for simulation were all white in terms of the skin tone. It wasn't until someone stopped me, who happened to be a black student, and say, is this the norm? Is this society? Of course it's not. So this isn't innovation, this is common sense. And this is about actually making a stance about saying we need to make sure the curricula diversifies as well. But the innovation piece also comes from how you work with partners in practice. We can't deliver the workforce of tomorrow without working with partners. The partnership working is ferociously intense at times. It has to be, because we need to make sure we are regulated by the NMC, Nursing Midwifery Council, HCPC, and a multitude of other regulators. That regulation sometimes gets in the way. Not because I'm saying you should create unsafe practitioners, of course not, but it does stifle, for example, how you develop and progress your simulation activities for learning and teaching. There's also, for me, so the third part of this is, as you were asking the question, Shane, is also about the phrase, don't just stay in your own swim lane. Because actually, I think back in my day, you were told, you're a radiographer, you crack on in that line, but don't cross over into X, Y, or Z. It wasn't until I was about 3 or 4 years into practice, I realised you had to work with other professions to make a better sense position for the patient. So actually, universities have got a massive role to play in making sure they smash up and break up what is traditional around programmes and make them in a much more multi-professional and interprofessional way. That's the innovation piece as well for me. And without that, I think we can pack up and go home, because patients and their families rightly expect this now. I could talk about digital, I could talk about that, embedding that within the curricula, but we also have a duty of care to those that are qualified and those who are working at the pre-qualification level. So it's the pipeline, making sure that innovation, workforce, research, which often isn't talked about. We talk about innovation, but empirical research is done to create betterment for society. And that's, I guess, where, as my final kind of plug, I guess, again, for the Integrated Care Academy, that's what we're trying to do, is work with people beyond silos to create difference and betterment.
Thank you, Marc. So we're all in danger of violently agreeing that we need a culture that works, okay? And therefore, I suppose the question I'd like to do and I'd ask of all of you is, what are the conditions, whether that's individual, whether that's organisation, whether that's systems, what are the conditions that we now need to create to enable that culture, given the situation we're in with the NHS at the moment? So I don't know whether, maybe start, as you have the microphone, Marc, go on that way.
Maybe say something which is a bit controversial here, but I think we need to accept the fact that there is a problem, actually, and there is a challenge, and that we haven't got it right. I think we also need to be accepting of the fact that the Western model of providing healthcare isn't always the best model, and I think it's one thing to import a workforce from overseas, and I'll just be frank here, but it's another thing to look after them and really understand the culture they're coming from, to actually look at innovative ways under sometimes quite extreme financial pressures. That's where you get your innovation. Doesn't mean you should always work that way, but I think we need to acknowledge, and then we need some people who've got great facilitation skills and to come together to solve it at system, regional and national level there. But let's not lose sight of who's at the heart of this, obviously the patient, but also the workforce. And we've heard today already about the burnout, the unattractiveness. I can't tell you the damage that was caused when the bursary went in 2000 and where are we now? Where was it? Was it 2012? It's a long time ago. That changed how mature students could access programs overnight. We lost a demographic that we've never got back. Not only that, but it did actually then have an impact on patient care. So these are systemic things that we need to change, and one lever being pulled somewhere by someone has a massive impact elsewhere. That's de-innovation, or whatever you'd call it, I guess, destruction.
Thank you. Just taking a different view and thinking of all of you in the room as leaders, and what can you do to help shape that culture that's so positive? And we can't control culture. I thought I could when I first started delving into this and measuring it. I thought then, all the solutions will become obvious. How do we craft and create the space and time? And as leaders, you control the space and time for the conversations to happen. How do you nudge the conversations to be about what matters? Be it civility, psychological safety, inclusion, equality, innovation. We can nudge those conversations, and we can role model and respond productively to what comes back, and be really curious about what others are seeing that we don't see. So how do we create those spaces where we can then do that? And this today is one of those spaces. Space for conversation, time together, build connection, understand, and get that sort of peer support for what we're trying to achieve. And there's a longer answer later, but we'll see if we've got time.
I'm just thinking about it in terms of ownership. Every culture isn't necessarily created from the top. And I think if we are sitting in that culture, we can shape it. We have ownership of it, it's ours. So quite often in the past, we've assumed that those bigger things are created from the outside, and we kind of put up and shut up about it. But actually, if we're in that conversation, we can shape it. And it's moving beyond the fear the fear of, humiliation, criticism, being ostracised, all of those things, even fear of losing your job. It's moving beyond that and taking real courage, I think, to break down some of those barriers that sometimes they're external, but sometimes they are internal as well. They're internal, generational things that we carry with us that we perceive to be fearful.
Thank you. So, we've talked about culture being work, as in creating culture is a job. It's part of our job. And we've also talked about the opportunity that we have as individuals and as organisations to create a culture. Okay? So in other words, we own the culture we live in, and therefore it's up to us to create that culture. It's not just about the external world. So I'd love to open up to questions from the floor to challenge any of our opening positions and see where the conversation goes. So we're not going to use Slido because the room's small enough, but if you do have a question, you stick your hand up and we'll pass the mic and then we can see what the panel think. Let's go there. Oh.
I am Suzanne Carroll. I'm the Managing Director at Wiltshire Health and Care, and I'm just wondering where we saw sort of the values and behaviours as part of the culture, because I think that's absolutely key to, as you said, shaping and forming it. And I think the comment you made that said often the culture is within the organisation. It's not the leader that creates it, but it's the leader that should respond to it and bring about the issues. And it's about all the sort of things about, as we say, behaviours, personalities, when you've got sometimes very grounded beliefs and practice and relationships that are operating around the organisation behaviour to address. I actually come from Shrewsbury and Telford, so very much aware of the culture and how it can invade the way that people approach their work and productivity and support for each other.
So who wants to take a lead? Matt?
I'll come in there and I'm going to tweak your language slightly and get us to stop talking about organisations and talking about people in organisations, because it shifts how I see things, and I don't know if that's helpful. And you're absolutely right about how we enact our values. And something we learned in the previous work in maternity and perinatal was that if we talk about culture over here, have a separate driver diagram, and have the other work over here, it stays separate and doesn't cross over into the work. And today we're doing culture, next day we're doing work. So there's something called moments at moments-safety.com. Just trying to understand how we enact our values in our daily practices. So how are we in a team together? Sharing all those perceptions across the hierarchies, and it's felt like a really safe space to open up those conversations. And it's just framed around competencies, meanings, materials, with the values playing out through that, and understanding what we may want to amplify, what we may want to bring in, and potentially what we may want to stop in the values that we're seeing. And we've heard here today about the biases. I have no idea, unless I ask, how I'm perceived by others. And I can think I've got the best values in the world, but unless you tell me, it's just my one view, and I may not understand how I'm impacting on you and the work that you do. So I'd steer you towards that if you've got time to have a look.
Yeah. Anyone else from the panel want to give a thought on the values concept?
Very quickly, just completely agree with you. And I think sometimes those conversations with students when they come back from practice, where they've seen difference, or they want to raise something, that's also a space where you've got to create that safety for them as well as learners, steering towards their profession. And sometimes that can feel quite tricky if you haven't got the right conditions for that. And that's where, again, working in partnership with our great partners in the NHS and the charities and the voluntary sectors is so important that we have that there for them. And actually that then does feed into things around EDI, and where in some cultures it's tricky to bring up certain things that have happened. So one has to cut across with an intersectional lens, actually, some of this stuff, because culture will mean things to different people in different parts of the organisation as well. Yeah.
Could I quickly... last few weeks I've actually been working on a tool that helps a very large multinational company spread over 50 odd countries develop values and behaviours, specifically 4 of them. And in those, they've given the staff the ability to challenge status quo. And that is an amazing, I trust you. I trust you to be able to do the right thing. And I think, that takes a big step. That's a big step in enabling everybody to come together.
Thank you. It's interesting. I wonder whether the culture in our NHS would enable people to answer that in the way that those people are answering it within that multinational organisation. And if they don't, what role do we play as leaders in enabling that to happen? Anyway, there's another question. David?
Yeah, I'm David Smallcombe, Chief Exec, Care and Support West, and anybody who knows me knows that I start from social care, not health, but social care partnership with health. One of the things I'd like you to maybe comment about is where could we get permission and requirement to change? Because it seems to me that change is significant. We've heard about all that today. But where can we look to get both permission and a requirement to change?
I think that it would be nice to have that, wouldn't it? It would be lovely to have that. Whether everybody's going to have that is questionable. So, sometimes it requires, I think, us to stand up and have courage to forge that from the bottom. Because the fear of those people at the top, and I think they will have really good reasons in the back of their mind why they shouldn't give that. They'll have all the great reasons they can think of. And that's what we do when we, as individuals, we think of change. We think, actually, we can't do that because we've got a very good reason. It's one of those human things that we go through in our thinking process. So if we're not afforded that luxury of, yes, we're going to give you permission, then I think it's for us to take that challenge.
Marc?
I think permission bit's a really fascinating piece to talk about, and a little bit about power and reflecting on things within Plymouth and how people feel really disempowered and that need permission, and fresh eyes going, well, why? You want to get on and do the best thing, please just do it. So how do we shift to that space where we have the agency to do what's best for the people we're looking after rather than seeking permission? I think assurance may get in the way of that. This ability to learn safely and try things differently. So how do we let ourselves, I'm going to say, be 10% braver in trying to do something a little bit different and learn safely? And it's different to what we're hearing this morning about radical change, but incremental learning. This is all right. Trust me a bit more. Yes, this is good. And building that way rather than having to be a all-out shift as well.
So I work in practice development in adult social care, and I think it's about using your platform where you can. So I'm a bit of a rebel, I wouldn't sound logical, but I am a bit of a rebel. And I think it's to nudge, and there's times when I've nudged where I shouldn't go. But in nudging, I've been able to start the work that I wanted to start. And I think sometimes you just have to, it's just those gentle prodding, isn't it, until you get where you want to go, rather than that trying to create that change.
I was just going to add to what you were saying there, Matt, as well. This is where simulated learning and where you have safe environments to test and fail there's nothing better than seeing, and I really mean this, watching, observing, then reflecting with students when something goes wrong in a safe, controlled environment. I'm saying that because the moment of realization about the harm that could come to patient or could come to whatever, and when you expose that in an environment because you set it up to look like, to feel like, to smell like what it could be in practice, that is so powerful. And yes, you can do that with social care as well. You can make living rooms, you can make houses look, you can make spaces look, you can make environments look exactly like someone's home or a care home or something as well, and involving a multitude of different professions. That's where difference is made, I think, and that's where the tried, the testing, the reflecting, and having that time built in for that, for your students or your workforce. And if it worries me the most, actually, it's the qualified workforce having that headspace to reflect upon what's happened in a day. And we saw the worst of that, unfortunately, in COVID, didn't we? Where there's just no time. I mean, there's hardly time now, I can appreciate that. But having that time to reflect upon what's happened as well, because these are the human factors, aren't they?
Can I just do a follow-up and then we'll bring more in? It's a really weird, strange concept, David, and I understand your question, that having to think about permission to do the right thing. That's conceptually a really strange thing. If we know it's the right thing, having permission to do the right thing, because actually would our patients forgive us for not doing the right thing? And it's a really, and I appreciate the question because it's a really important question, but actually the concept of a culture wanting permission to do the right thing is a bunch of negatives that are in a sentence which isn't quite right. So there's something quite interesting about that. Question at the back, and then there's question at the front as well. Alex,
yeah. Hi, Israel Betchku, ICS Chief Pharmacist, PSW. I suppose an observation is, or a thought is about how much of the resistance to change is based on the fear of almost losing or retaining existing power structure for the professional organization, for instance. We've spoken quite a fair bit about psychological safety, and lots of mention about the pandemic. One particular episode stood out to me, and there was a very prominent surgeon or anaesthetist that's not an Imperial who said loads on Sky News about not liking the vaccine or whatever, made the news, and the next day I think there was a paper that called them the bravest clinician in the UK or something. And what struck me at the time was, would that have been the same reaction if it was a HCA, say, of Bangladeshi origin? Would that have been? And what also struck me was the silence from organizations afterwards. And so, with that in mind, my question is at what point and how do we ensure, almost have the responsibility of organizations to create that space and for ICBs to hold them to account for that culture, for that psychological safe space that allows people to speak up, because that's where your safety culture comes in. That's where your creativity comes from, when everybody's able to bring themselves to work properly.
Thank you. Marc, you want to go on then?
I'll be very quick. The word speak up and freedom to speak up have become different for me over the last couple of years. That's my own personal journey as a white man sitting here. I've seen it through the lens of my non-exec role at UHB and Western. We do need to make those conditions, you're absolutely right, and that involves having, again, I go back to honest conversations about power, difference, and the fact that, particularly for students, if you think about this, compared to when if you're not a student, and particularly when race is involved and other dimensions as well, having honest conversations, calling out, having pledges, having support at system level is really, really important, as is having the learning resources to help people along the way as well, because if we just punish people then for not understanding, that's maybe not the right way to go. We've got to help people as well, so that way you start to actually create a safer, I think, cultural environment. I've given a very broad answer there, but I completely understand what you're saying.
Matt, do you want to come in and then we'll go to the final question? Then.
Just very quickly, I think the role of the ICBs is fascinating. The holding to account may be unhelpful. I'm going to say, what's their role in helping to craft those conditions rather than holding to account? Yeah. I think it just creates a different conversation, different dialogue about how we all achieve what we want to achieve, rather than setting us potentially against each other. So just to shift that.
We have the final question.
Super, thank you. So Helen James from VCSC Nutriri, we're working to create stigma-informed systems and co-create weight-neutral triage to reduce healthcare inequalities. My question is about, I think people, my observation is people want to be contributory and creative rather than critical. So like we have a yellow card system, our time-pressed clinicians and our workforce haven't got the time to be innovators, but they certainly have a large piece of the puzzle for innovation. So could we create perhaps a green card system that, you know, we can just partially write down part of a solution or an observation that will get collected up by those that have more time, an innovation network for instance, and put them in touch with the innovators that are working in that field. Because over 9 years we've been developing our training with workforce, you know, not just with citizens from lived experience, the lived experience of the workforce day in, day out at the coalface of care. So, yeah, green card.
Green card. Suzanne?
I mean, I love that idea because that's what I do for a job, you know. That's what we do. We collect all of those insights and, you know, try and influence the decision makers with those, you know, solutions from the bottom up. Yeah. One thing that I just wanted to add, we always talk about the risk of change. What we never talk about is the risk of staying the same. And yeah, you've got it. So you know, I think it's inevitable that change will happen. It's inevitable that change does happen. So, and quite often when you're in a relationship with another person or with an institution, it really is about if things don't work, then they have to change, you know. And leaving it for years means years of misery. Whereas if you actually start realizing that the change has to happen now, then there's a chance of it improving.
Can I say thank you to all panel members? The idea today was to wander through the issue of culture, how we can impact culture, we can change culture. I think culture is work. We need to think about our culture and we need to do about our culture rather than just talk about our culture. I love the analogy of it being like a marriage. Okay, I think that's just a fabulous way to, which we've got to work on it and things have to change at times. So can I say to the panel, thank you to you, thank you for the questions. I hope you found it very useful. I certainly did, so thank you very much. Brilliant, thank you.